Hello, everyone. I hope you can hear me. I hope you had a good break as well. We've just had some technical gremlins and we've had to go over to sharing a screen share of a Teams call instead. But thanks for your patience while we work that all out. This session is a panel discussion on palliative care service planning, giving choice at the end of life. I'm pleased to introduce our chair, Professor Iain Atherton, who will lead today's conversation. Over to you, Iain.
Thank you very much, and thank you to all your colleagues for sterling work in sorting out our technical problems. Yeah, delighted to have the opportunity to chair this session. I'm Iain Atherton from Edinburgh Napier University, Professor of Nursing and Data Science. I'm a registered nurse. A big part of my work has been around end-of-life care, palliative care, and a lot of my research likewise as well. So delighted to have the opportunity to present this session. We've got three people who are going to contribute to these discussions. Absolutely delighted to have my colleague, Iain Savinc. Iain Savinc is a research fellow in health data science, works along with myself at Edinburgh Napier University and as part of ADR Scotland. He's got a range of research interests. They all revolve around the use of large data sets to collect routinely collected data by public bodies for research into public health. And he's interested in areas including mental health, childhood adversity, suicide prevention, alcohol, drug use, and educating the public about the use of data and end-of-life care being a major one as well. Delighted also to have Fiona Williams. Fiona is a clinical nurse specialist in palliative care. She's got 25 years experience working in that area, majority of which has been as a community practitioner in the west coast of Cumbria, a beautiful part of the world. Currently, she's based in hospital and is enjoying her second year of a secondment bringing research into underserved communities within Cumbria. She's got a degree in health studies and a master's in medical ethics and law. And thirdly, we have a colleague here, Grace Rowley. Grace is a consultant in palliative medicine in North Cumbria, originally trained and worked as a GP before converting to palliative care, having developed a passion for the speciality working in hospices and as a palliative care mentor in Tanzania. And she's completed a master's degree in medical education. So that's our panel. What we're going to do is I'm going to ask each of our panelists to talk for 5 minutes on the topic of palliative care service planning, giving choice at the end of life. So I'm going to start with Fiona. Fiona, do you want to have your 5 minutes? Ooh, I just need to unmute yourself.
Apologies. Yeah, we have to talk about palliative care, service planning, and giving choice at the end of life. I think for the first thing for me, as I make think, why is choice important? Because choice is really important. So that's kind of what I want to start with. Choice really matters. If we don't ask the questions, we will have absolutely no idea of what is important to people and how we then proceed with the care we need to give. Cancer, end-stage heart failure, end-stage respiratory disease, frailty, and people with multiple comorbidities, all these conditions are incredibly impactful on your life. It also limits the options that are open to you, the choices you make, and it reduces independence. And that, or it can be taken away completely. And that is where we sit really with all this. It's essential we ask people what's important to them, especially when they're coming towards end of life. At this time, there are many things that are being taken away from people when they're coming towards the end of life, like their independence. And this gives something back. It actually provides people with a little bit of agency again and the opportunity to be heard, which is massive. To be honest, you're often surprised what you get when you ask what's important to you. I've had patients that refuse to come into hospital because there's nobody to look after their cats, despite needing it to. So you're never quite sure where it comes to. So Iain's asked us to put along a couple of really brief case studies. So I thought the two that I wanted to discuss with you where the decisions I thought were about to be made weren't actually. So we've got a lady, Helen, who's 59. She was admitted with jaundice and was found to have new diagnosis of pancreatic cancer requiring stents. She'd just come out of a long-term relationship, actually, about 23 years of coercive control and emotional financial abuse. So asking Helen what was important to her, she said that she wanted to share the last few months of her life at home and be supported by her sons, who all three of them had agreed to come back home to look after mum. She was actually, to be honest, quite a complex discharge. It required extensive communications with the police, a restraining order, a variety of care providers, GPs, district nurses, hospice at home teams, and specialist palliative care team, and myself. So to manage these symptoms and support, how we supported this when we got this lady home, we did what we call an emergency healthcare plan. And this was to enable these complex symptoms to be managed well at home. There was also documents, don't resuscitate documents that had to be put in place, fast track care, which funded the care 4 times a day. And we also got support from the local hospice to allow the lads, her son's, time off. I mean, thankfully, Helen died peacefully at home, but it was a wonderful example of how it's not what you expect, and you'll need an awful lot of input from a lot of people. On the other hand, I have a lady just last week, Jane, who's 47. She'd separated from her husband and moved back home about 6 years ago with her son to live with her parents because her dad needed support with some dementia that he was struggling with. They live in a really small, rurally isolated community, very limited services. But unfortunately, earlier this year, she developed a really aggressive bowel cancer. And after numerous admissions to hospital and surgical interventions, unfortunately, the decision last week was for best supportive care. She came in with a bowel obstruction, which is tricky to manage, and her condition was rapidly deteriorating. And Jane had been a very feisty lady who was very clear about her wishes, and she'd always wanted to be looked after at home. However, managing her overwhelming distress and taking the time to have some conversations to unpick this, what was important to this lady was that it became apparent she hadn't discussed her prognosis or the extent of her disease with her parents or her son, so they were unaware that her life was going to be ending in short days to short weeks. So unpicking what she wanted, what the thing that was most important to her was that a 10-year-old son is supported. And so looking at her very rural home and the lack of services at night time and how to have good symptom management, we ended up negotiating for her to go to a hospice, which, because we're in the Lake District's about 90 minutes away. And there we were able to do some fantastic legacy planning with her son. He was going to be well supported in a very short space of time. It allowed her mum to just be a mum again, rather than the carer, not just for her husband with dementia, but for her daughter. So again, not the result I was expecting, but sometimes you have to ask the question. It's amazing. You have to respond to what comes back. Okay.
Thank you so much, and impeccable timing with 20 seconds to spare. So, Grace, can I hand over to yourself there?
Absolutely, and it's where do you start sometimes when you're thinking about these things. We've had a lot of discussion when we've been thinking about sort of giving choice at end of life, and I guess one of the big things that came up for me is actually recognizing that someone is at the end of life, and that is one of the challenges we face. And I think an example would be, it's not unusual for us as a hospital team to be referred patients sort of that day, and we will go and review the patient, and actually by the time we've got to the patient, we've they've been asked for an urgent discharge home, and by the time we've got to see the patient, which is within that day, the patient has died. And it's not unusual that patient has been in hospital potentially for several weeks. And the point that we're recognizing that patients want to have some choice and want to think about going home at end of life, potentially, if that's their wish, we've almost missed that window because it's being identified too late. So one of the things that we do see is that recognition of dying, and maybe if we recognized and started these conversations earlier and finding out what patients want, we wouldn't necessarily be sort of having these panics and trying to organise discharges. It's not always the case, because sometimes things change quickly and we do have to think about urgent discharges. Another example would be, even if we've thought about these things, sometimes things do change. And we've had a patient recently in EAU, which is our emergency ward, on the ward, who had been in for 3 days, so not a long period of time, and had known lung cancer and had been deteriorating during that stay, but they'd been trying treatment for them. So it was appropriate they had been in that time, but actually we got to the point where it had become apparent that the treatment wasn't being effective, and we were looking at a patient who was end of life. We had a very small window at that point to get this patient home, and so one of our jobs is to go in and have a think about what's needed for this patient. You know, if they were very keen to get home at end of life, and we think about things like, do they need a hospital bed? Do they need carers to come in to support that care? And the reality was, the things that were identified that patient needed, we could not get in place because there wasn't the capacity for the response to be that quickly, and the patient ended up dying in the hospital. And that was a patient who was keen to die at home, and we were not achieving preferred place of care. And it's not unusual that patients are sat on wards for long periods of time awaiting nursing home beds. And so I think there's two themes that really have come out. There's the sort of the theme of, we need to recognise earlier and maybe start having conversations earlier. You know, that what would wishes be when things change, and I think a lot of work is being done with that, about thinking about how can we identify these patients, but also thinking about, actually, do we have the resources to then be able to respond to what people's wishes are, and how does that mismatch, how does that work?
The screen share live. Thank you. Sorry about that, everyone. We lost a few of probably the last 10 to 20 seconds of that. I'm so sorry, Grace, but I think we're back again. Right, I will disappear again now.
No, you're fine. So can I just double check? We just lost the last 15, 20 seconds, yeah? So, Grace, I don't know if you want to just conclude again, sort of recap of your last sort of 30 seconds or so.
Yeah, so the gentleman that I was talking about, who we wanted to get home and who we needed to get IV antibiotics into, so there was a real conflict of, does he stay in hospital or does he go home? But without the IV antibiotics, we actually, between a lot of work with a lot of different people, he managed to go home with an indwelling a PIC line in place, and some amazing district nurses who are administering those antibiotics. And so I think there are times when mountains are moved to get people where they want to be.
Brilliant. Thank you very much. And thanks again to our colleagues for sorting out the technical gremlins. Iain, can I ask you to have your 5 minutes?
Sure. Thanks, Ian. So going back to the subtitle of this panel, the giving choice at the end of life, I was thinking about the context that this choice happens in. So people making decisions at the end of life based on what services are available to them, based on where they live and how far these services are, as we've heard, and so on, and whether they've got access to care, unpaid care. I've been doing research using routinely collected data on this wider context on a nationwide level in Scotland, and specifically how that context has changed since the COVID pandemic. And specifically, I've been looking at the increased number of people who died at home during the pandemic, and the increase in home deaths basically since the pandemic as well. And also how the demographic profile of people who died at home has changed, and how people engaged with health services in their final 12 months of life. Just a sort of very high level overview of this, the number of home deaths in Scotland increased by about 35% during the first year of the pandemic, which, as you can imagine, is a massive increase of the number of people engaging with community-based services. And since the pandemic, approximately a third of all people who die in Scotland die at home, and that's up from about 25% before the pandemic. So as I mentioned, my research uses data held by public bodies. So these are routinely collected data by the NHS and by National Records of Scotland, who collect death registrations. And I've been able to link death registrations between 2015 and 2021, so the first year of the pandemic, and link them to people's health service use in their final 12 months of life. This includes admissions to hospital, prescribing data, and unscheduled care data. Unfortunately, palliative care specifically isn't available on a nationwide level. There are various regional data sets from specialist services, but for this sort of nationwide work, I've had to make a couple of proxy measures, such as inferring whether people had palliative care needs based on their cause of death and their hospitalizations in the final year of life, and also things like looking at prescriptions for medicines that are used in anticipatory or just in case use cases. What the research has showed so far is that we're really seeing an increased demand for community services as a result of these increased home deaths. And also services very early in the pandemic also restructured to better provide community care and care at home. The demographic profile of people who died at home has shifted. So people dying at home are now older than they were before the pandemic. They're more likely to be male and married. And they also have a higher level of multimorbidity and a wider range of medicines that they were prescribed. So what we're seeing is a kind of shift from people dying in the hospital to dying in the community, both in terms of the relative proportions of where people die, but also in the kind of complexity of care needs. So especially with multimorbidity and this high range of medicines now also being more likely at home. We've also found that hospital admissions for people who were dying at home were shorter and people were discharged home earlier. So on the whole, people were spending more time at home in their final 12 months and therefore more likely to then engage with home-based services. So kind of as a conclusion to this, thinking about the context in which people make choices at the end of life. In Scotland, this context has changed quite a lot with the pandemic. We know from sort of these survey studies that people prefer to receive care or to die at home. So in some ways, this has accelerated sort of enabling this kind of choice, although during the pandemic, how this happened, of course, is debatable. But what we now see is that more people are dying at home, and that a lot of services have kind of shifted towards supporting people who are dying at home as well.
Thank you very much, Iain, and indeed thank you very much to all of our panelists. So to open up to discussion, we've heard about the challenges of enabling choice in often very challenging, difficult situations, and we've also heard that that has only accelerated across the population, certainly in Scotland and likely more widely as well. So yeah, I wonder to what extent it's realistic to talk about choice, especially given funding constraints. Perhaps Grace, can I come to you first? Do you want to comment on that?
I think one of the challenges with patient choice is actually having those conversations. And I think patients need to be able to explore their choices, and we don't always provide that situation until sometimes it's too far down the line that they're not in a position to really explore what their choices are. So an example would be a research project that we did with the home ventilation team for our region. And we interviewed all the clinicians from the team, but also patients involved in that team. And a lot of it was about advanced care planning, because if we don't do the advanced care planning, we don't know what their choices are to then be able to try and sort of do some planning in place. And interestingly, the biggest thing that came out from both sides, patients were tentative to bring it up, because if it hadn't been sort of spoken to them about that they were maybe in their last year of life and maybe we need to think about that, they didn't want to suggest that. But clinicians quite often didn't feel that they had the experience to start having these conversations with patients. So I think that is one of the things that I think is a challenge. But alongside that, I think we're also seeing a lack of continuity of care, that maybe 10, 20 years ago, we had more continuity with general practitioners and from that study and observations, I think particularly in the community, there isn't the same opportunities in that sense to sort of really have those discussions to then go, right, what are your wishes and how much choice can we provide in that?
Yeah, really interesting. Fiona, do you want to comment on that?
I think it's really interesting. I think on a really basic level, some of the problems we have is equipment. We can't, people like, if we're going to have nursing interventions at home, the carers, we need what's called profiling beds, so they'll go up and down so nurses and carers aren't hurting their backs. And there's a limit to how many there are. And I've got couple of people at the minute who are bed blocking, you could call, because the equipment's not ready for them. They're not able to get them. And also, right in the minute in one of our cities, Carlisle, I can't get a fast track discharge to a nursing home because there's no beds. And we can struggle with getting care at home. So we've got quite a significant blockage because of equipment and care, really. Never mind the really complicated bits of care we do. This is just the basics.
So, Iain, we've heard the challenges from the point of view of clinicians. Given this increase in deaths that we've seen in Scotland, like I say, that's quite likely been reflected across the UK. Do we have any sense as to the extent to which people's wishes are being met, or is this something that you're going to be able to look at with the data?
Yeah, so like I said, we know from survey research that people's preferences are generally to die at home, but of course this differs with everybody's situation and can also change over time as people's condition changes at the end of life. Unfortunately, data on advanced care planning or patients' preferences aren't collected in a way that enables research on a nationwide level. Although I think you can find sort of local systems that record these things. So I think the direction of research there is probably going to be sort of investigating these on a more regional level, and then also trying to think about whether we can design a kind of minimum data set for collection for palliative care services, and that would include things like recording patient preferences as well. So as far as I'm aware, there isn't currently a nationwide palliative care data collection, and there also isn't a sort of minimum data set for this sort of thing in Scotland.
Really interesting. There's a few things you said there which I'd like to come to Fiona and Grace with, but before I do that, and given what we've sort of moved into thinking about research, perhaps Fiona, if I can come to yourself, I mean, what are the things that keep you awake at night? What are the questions that you would like to see answered? That we just at the moment don't have evidence to really make decisions.
I think interestingly, I think the minimum data set would be a genius idea, because different GPs, different services, well, different healthcare use different platforms, and then we all know how difficult it is to get for those to speak together. So I think the minimum data set would be a genius idea. I think what keeps me awake about, we were talking about this is a stack of things. The main one, this may be a local problem because we've had quite rural work. Carlisle or Whitehaven, so we're in Cumbria, we were struggling with staff, and we got a lot of staff brought in from overseas, which is great because we've got more staff now. The interesting problem we've ended up with is that different communities and different ethnicities have a different approach to palliative care, or it's not part of their vocabulary. So we've ended up with a lot of healthcare professionals who literally can't talk about death and dying, and it's part of their culture. You treat somebody till the point where they are dying, you don't stop, or else you're going to be in trouble. So we've had to do an awful lot of education, haven't we? You've done an awful lot of training with consultants, with staff, with new nurses to educate them really about what palliative care is. So I'd had 2 years out in research, and I came back and I thought, we've gone backwards, what's happened? But it's great, we've got more staff, but we've had and it's those really basic conversations, how you even have that discussion with a patient, like, we've done this, we've done that, unfortunately things aren't working, we need to change our focus of care, and can I suggest, and what's important to you? They were unable to have a conversation. So that's the main one. But we've done something about it, done a lot of education.
Grace, do you want to add to that? What are the things that keep you awake at night, Grace?
Oh, I think there's lots of things. I think inequity sometimes is one of the things certainly that we see, and I know they talk, and I don't like the term a postcode lottery, but there ultimately is an element of what's available and what's is that going to allow your choices to happen. And we do have situations where patients in one place would be able to stay at home, whereas actually we cannot meet their needs in another place, and staying at home isn't an option, and all of that feeds into the patient choices, because one of my first questions when speaking to a patient is, what's your priority in all of this, what's important to you, what sort of, but with that it's then trying to sort of find out about that, but then how do you allow them to have that choice if we are not able to meet those needs then? So it becomes quite hard when you're having those conversations, but then also thinking, right, how can we meet this need, because this is going to be a challenge.
Really interesting. So Iain, if I can come to you next, and Iain, I wonder if you and Fiona teed this up on purposely. So Fiona suggested that the minimum data set is a genius idea. That is something you're developing. So how do you think that will help both in terms of patients and in terms of clinicians, such as Grace and Fiona? What are the kinds of things that you have in mind with this minimum data set?
Yeah, so the idea with the minimum data set is that it would allow sort of collection and comparison of data from various services on a nationwide level, which would allow us to see, like we were saying, because these choices people make at the end of life, they really depend on the context. So whether people live rurally or in an urban area, that sort of thing. So it would allow us to look at how service provision differs by across the country, whether it's different between different places. One thing that I was thinking about in the previous question about this, what keeps people awake at night, is that we also don't collect data on the people's subjective experiences of care and whether they received good quality care and whether we're enabling good quality death at the end of the day. So it would be great if we were able to collect data on this as well. But I'm also very aware that sort of part of the reason to design a minimum data set for collection is also because the collection of data is quite onerous, and all of these services are already sort of doing their best. So asking people to collect more data is difficult. But yeah, I think for research on a kind of population level, having a standardized set of data that all of these services will be collecting would be really valuable.
That's really interesting. And given the work that you've done and the increase that you saw, I mean, that must have been incredibly challenging coping with. I mean, Fiona, Grace, I mean, does it come as a surprise to you that there was such a large increase in home deaths and that it continues through to the current day?
I hope, and it's that difficulty of sort of knowing. I hope this is a positive, because sort of data generally suggests that people predominantly prefer to be at home, and sometimes that's not possible. But actually, if we're seeing that fills me with hope that maybe this is something that we can do. And I guess it's then extrapolating it and going, how is this been possible, and sort of what can we learn from that? And so I'm really encouraged by that data, and it's trying to work out why there's been that shift and how we can keep those options there for people.
Yeah, I read your paper, and I just thought, whoa, we've been after this for years. I've been doing this job for over 25 years. I think we're actually getting there. It's nice to see we're moving in the right direction. But what we do acknowledge, and the way the jobs and the roles changed in the last 5 to 10 years, way more complexity of what we're having to deal with, and then try and manage at home with sometimes fewer services in some ways. The services don't appear to have reflected the complexity of what we're seeing. What we can manage at home, given the opportunities, is incredible. We've got people on home ventilation, there's people on TPN feeds at home, feed fed into a there's a ton of stuff that is possible if we've got the care. Again, we're very postcode lottery here, so it's challenging.
And I guess these challenges sort of, they're not just about people with expertise in palliative care. My guess is that people across specialities, palliative care is something that they are likely to engage in. People, the conditions change, and so yeah, I was very struck by what you were saying about the educational needs. And clearly that's a key part of the NHS 10-year plan. I mean, perhaps, Grace, if I can come to yourself first, what do you see as being the key educational needs across NHS England and indeed more widely across the UK?
I think one of the big things, the thing that actually one of the things that keeps me awake at night is the way we're seeing it. We know the population is rising, and how are we? Or certainly the more elderly, the more frail people are potentially living longer. People having cancer treatments, amazingly, people are staying alive for longer, but with also all the challenges of complex disease and the side effects of treatment. So we've got an increasing frail population that we sort of need to meet the needs for. Certainly our small palliative care is just a tiny part of that, but it's upskilling everyone to be able to deliver good quality end of life care, because I think it needs sort of the whole workforce really to be competent, to feel that they can have those conversations, to feel that they can deliver the sort of, you know, the general end of life care, because it is a general thing that sort of everyone needs to be. And I think with that sort of that education out into the wider sort of communities, and I know it's sort of the huge sort of movement with compassionate communities, sort of going, actually, is there more as communities we need to be doing, as we recognise that this population is getting bigger, and it needs to be sort of everyone involved in that. So where does that education stop? And, you know, it's a big thing if we're rolling a lot of this out into the community.
Yeah. And it's a thought was crossing my mind as you were talking there, and perhaps Fiona, if I can come to you on that. I mean, a big part of the NHS 10-year plan is to see increasingly care provided in community settings. I mean, how realistic is that in terms of enabling end-of-life care and enabling choices?
I think it's always going to be a challenge, because it's going to be resource led, that one, really. We've got really basic problems with getting carers. We've got pockets of small communities, and so we've got a limited ability to get care and get staff from that. I think it's interesting, because we've had a couple of interesting issues recently. I think we are absolutely lacking in places where we can not. People sometimes fall between groups, that they're too poorly to be at home. They're not quite well enough to be at home. They're too poorly to be in hospital, or the other way around. And we sort of need a place where it's almost like supported living, don't we? For young people. Otherwise, they spend months and months and months in hospital, and we haven't got anything like that here. I think you said there was something over in the northeast, didn't you? So there's. And how we look after the complexity of care in hospital, whether we've got home ventilations or we're doing peg feeding into tummies and all sorts of things. There's a lot, and the services aren't around, unfortunately.
Well, I see that's thank you very much for that. And indeed, thank you to all our panelists. I'm just seeing Fiona coming online there. I'm aware that we're just about to hit 20 past, so a huge thanks to all our panelists. And Fiona, I'll hand over to you there.
Thank you so much, and thanks everybody for your patience, like working through all this technical stuff. I really appreciate it, like such wonderful insights. I love the contrast between the numbers from Iain, and then the really personal stories as well from you both. So yes, thank you, and thank you so much, Iain, for your awesome sharing. So that's the end.
Thank you.
That's the end of the panel, and we've got 3 lightning talks, and then we'll be back in the main room for the closing remarks at 4:40 p.m. So 20 minutes. So you can catch a quick lightning talk if you want to. But otherwise, thank you again. See you later.
Thank you. Thanks, everybody.